some of the key performance indicators in radiotherapy. How do we measure quality and what does it mean? What do we actually pick up? So here are the learning objectives for this very short talk today. So first of all, how did the National Prostate Cancer Audit develop the radiotherapy performance indicators? How did we validate these performance indicators in radiotherapy to check we were measuring what we wanted to measure? And how can these performance indicators demonstrate hospital variation between hospitals? And most importantly, how does this reporting and all of this very hard work improve the quality of the care, which is, of course, why we've got so many of you on the call today, and it's great to see so many people joining. So why is there so much invested in this work in the UK for prostate cancer? Well, this is a different example, but one that I found very powerful. And this is work led by an amazing guy called Atul Gawande. If you haven't read any of his books, I would really recommend them. And he's a US doctor, and he was one of the team that came up with the surgical checklist, the WHO surgical checklist, which you may be aware of. It's a very simple intervention designed to reduce avoidable harm from surgery around the world. And it's incredibly simple. It's things like, checking the patient's name. Does everyone know everyone else in the operating theatre? What operation are we doing? Do we have all the right kit? Things that you would think would be sort of no-brainers. But actually what they've shown in a variety of different healthcare settings, and I've just highlighted the key table here, is that even in high-performing and low-income countries, this very simple intervention reduces the chance of dying from surgery and reduces the risk of complications across different healthcare scenarios. So I think this is a very powerful example of how simple measuring and intervention can improve outcomes. So long before I got involved, the team were doing all the very hard work of the methodological development of the National Prostate Cancer Audit, because what comes into the audit is a range of data from different national sources, and there's different pros and cons of different databases and different data streams. And so what the team needed to do is to prove that what we measure from this data actually means something. So we needed to find objective clinical indicators, and also that we had a round of patient-reported outcome measures, which is particularly powerful. And the focus was really on mid to late toxicities. Acute toxicity, particularly in radiotherapy, comes and goes, but what we wanted to focus on was the more longer lasting side effects. And for prostate, that means bowel side effects, GU side effects, so bladder symptoms, and sexual function. And it took between 2 and 3 years to develop these indicators and then validate them to compare practices of care between hospitals. And so a lot of very important work went into this before anything came out of it, as it were. And so these are some of the early papers looking at validating what comes out of the data and showing that it's meaningful in terms of the indicators that are published. And this is the original National Prostate Cancer team, many of whom are still involved in the audit, which is fantastic. So today, in the first half of this session, we're looking at radiotherapy, and one of the historical limiting factors of radiotherapy has been bowel toxicity. So for this toxicity indicator, we use hospital episode statistics, so HES database, and that is also linked to the cancer registry and the radiotherapy dataset, so 3 separate sources of data which are linked together. And this is based on assessment of pre-specified procedures and diagnostic codes. So for example, patient goes into hospital for a colonoscopy or a sigmoidoscopy, and then they're diagnosed with something, a diagnostic code that links to something related to radiotherapy. So, for example, they go in and have a sigmoidoscopy, and then they're coded as a radiation-induced proctitis. So it's not enough just to have the investigation, you have to have an associated diagnosis. And this provides a transparent mechanism for comparing the performances of different providers up and down the UK. I'm just going to briefly highlight a couple of examples of how this has been used to validate the indicators that we get. So firstly, this data here from comparing the outcomes of men having IMRT, which is now, of course, standard of care, versus those still getting 3D conformal radiotherapy. And this obviously was done 10 to 14 years ago now. And what you can see from this graph, as we would have expected, is from the data coming into the audit, we can show that those getting 3D conformal radiotherapy have a higher incidence of significant bowel side effects, and the IMRT appears to reduce this risk. So this backs up data we have from other sources and provides validation that what we are picking up in the NPCA is a real signal. And then the second example I wanted to show you was for patient-reported outcomes. So the audit did an amazing piece of work where they sent out patient-reported outcome measures to over 17,000 men diagnosed with prostate cancer between 2014 and 2016, who were 18 months or more after diagnosis. So we're really picking up that later toxicity signal. And quite amazingly, they got a 77% response rate just from this blanket sending out of patient-reported outcomes, which is really encouraging. And what this data showed with relationship to fractionation was that there didn't appear to be any difference in patient-reported bowel outcomes or urinary outcomes between the two fractionations. So comparing our old standard, which was 74 gray and 37, with the now standard 60 gray and 30 fractions. So this again mirrors what we saw from the CHIP trial and randomized trials around the world, that this change in fractionation doesn't impact long-term toxicity, and also then indirectly validates these measures from the audit as valid. So this is a paper that was published in Lancet Oncology a couple of years ago by the audit team, really talking about public reporting of outcomes in radiation oncology. The surgeons have been doing this for a long time. They publish a lot of their outcomes, and that's part of their ethos. But I think in radiation oncology, we haven't been at the forefront of reporting outcomes for our centres. But I think what the audit has shown is that this is feasible to develop outcome indicators for radiotherapy treatment that correlate with quality and patient-reported outcomes. What about hospital level performance? So there are said to be 51 radiotherapy centres, although some of those have satellites. And one of the indicators that we publish in our reports is the incidence of grade 2 or higher bowel complications up to 2 years after radiotherapy for prostate cancer. And these are published, you might have seen it on the database or in the reports, as funnel plots, which shows the variability between centres against volume. And I'll show you an example in a minute. These are adjusted for age, stage, and socioeconomic status and comorbidity, and it's really to flag up if there's any centres that are outliers. It's not to directly compare centres, it's just to alert if one centre has a very unusual level of side effects, and that might be for many reasons. So as I say, this is not with the intention of ranking centres, but it's just to flag if there is one centre whose performance is further from the average than you would expect to occur just by chance. It doesn't occur for differences in radiotherapy practice, as that might bias the analysis. So I think it's fairly universal. Everyone gets IMRT now, but historically we haven't accounted for that sort of thing. And it reduces the likelihood of misclassification bias by using a standardised coding approach. So it's the same across the country. One of the problems we have in trials is that people grade toxicity differently. Doctors might assess one patient differently between them, but this avoids that kind of bias. So in the most recent state of the nation report, we've benchmarked that around 10% of men in England and 5% of men in Wales experience at least one gastrointestinal complication within 2 years of radiotherapy, which is similar to what we see from trials as well, once again validating this data. And this is what I was referring to as a funnel plot. So the confidence intervals are here in the lines, the 95 and 99% in the red and green here, and the dots are all the 51 centres across the UK, in England, sorry, not the UK. And the red dots are the negative outliers, and the green dots down here would be positive outliers, if that's such a thing. So what happens when we flag this up is that we go back to that centre, because it may be a data entry thing. There may be not all their data went in, or it went in incorrectly. But sometimes when that doesn't appear to be the case, it stimulates an internal review of things like contouring, margins, setup, the constraints used, and bladder and bowel preparation protocols. And this is hopefully a positive thing. So hopefully that we're upskilling everyone's practice gets better. And what the audit has shown is that this process of outlier talking to the outliers has improved the outcomes in terms of toxicity and also reduced the variation. So I think you can see on that graph there at the bottom that the confidence intervals, the variability between centres is shrinking over the last few years. So that's an encouraging sign that actually this kind of intervention can improve quality across the UK, which of course is what we all want. So I think that's the end of everything I needed to say. Thank you very much. And with that, I'll hand over. I shall attempt to